In the world of emergency medical services, we distinguish between sick patients and really sick patients. Immediate life threats are conditions that will kill a person within minutes if not addressed. As an EMT, you are trained to identify these during the primary assessment using the XABC or CAB sequence. If you find a red light in any of these categories, you stop and fix it immediately. Section 1. X. Exsanguination, massive hemorrhage. Before you even check an airway, you check for exsanguination, severe uncontrolled arterial or venous hemorrhage. If a patient is bleeding out from a femoral artery, they can die before you even get a blood pressure cuff on them. The fix is aggressive. Apply direct pressure immediately. If the bleed is on a limb, apply a tourniquet high and tight until the pulse disappears and the bleeding stops. For junctional areas like the neck, armpit, or groin, use hemostatic gauze for wound packing and hold pressure for at least 3 to 5 minutes. Section 2. A. Airway emergencies. If oxygen can't get in, nothing else matters. We look for physical blockages like the tongue, food, blood, or vomit. For a choking patient, use abdominal thrusts. For an unconscious patient, use manual maneuvers like the head tilt/chin lift or the jaw thrust if trauma is suspected. Clear fluids with suctioning and secure the airway with adjuncts, an OPA for those without a gag reflex, or an NPA for those who can still swallow. This section also includes anaphylaxis, a severe systemic reaction causing airway swelling and low blood pressure. The immediate treatment is the administration of an epinephrine autoinjector and high-flow oxygen. Section 3. B. Respiratory and thoracic trauma. Thoracic trauma involves injuries to the bellows of the chest. In trauma assessment, we refer to the deadly dozen, but as an EMT, you are responsible for finding and treating the lethal 6 during your primary assessment. Airway obstruction, tension pneumothorax, cardiac tamponade, open pneumothorax, massive hemothorax, and flail chest. An open pneumothorax, or sucking chest wound, allows air into the pleural space, collapsing the lung. You must apply an occlusive dressing taped on 3 sides. This creates a pressure-driven one-way valve. On exhalation, internal pressure pushes air out. On inhalation, the dressing seals shut to keep air out. If the patient's condition worsens, you must burp the seal, lifting a corner to allow trapped air to hiss out and relieve pressure. Flail chest occurs when 2 or more adjacent ribs are broken in 2 or more places. You will see paradoxical motion, where the floating segment moves inward while the rest of the chest expands. Treat this with high-flow oxygen and positive pressure ventilation via a bag valve mask to splint the ribs from the inside. A massive hemothorax is when blood fills the pleural space. This collapses the lung and causes shock. Treat for shock by keeping the patient warm and supine. Provide high-flow oxygen and transport rapidly. We also watch for pulmonary contusion, which is bruising of the lung tissue that prevents oxygen exchange. Monitor SpO2 closely and provide BVM assistance if the patient begins to tire. Finally, look for traumatic asphyxia, caused by sudden, massive compression of the chest. You'll see bulging eyes and a blue-purple face. Your priority is immediate removal of the weight and airway management. Section 4. Obstructive shock. Obstructive shock is a mechanical failure where the heart is willing to pump, but a physical obstruction prevents blood flow. In a tension pneumothorax, trapped air collapses the lung and pushes the heart, kinking the plumbing. You will see JVD and absent lung sounds. In cardiac tamponade, blood fills the sac around the heart, squeezing it so it cannot fill. Look for Beck's Triad, muffled heart sounds, JVD, and narrowing pulse pressure. Both are surgical emergencies requiring rapid diesel therapy. Section 5. C. Circulatory and medical threats. If the patient is unresponsive and not breathing, you flip to CAB. For cardiac arrest, start high-quality CPR and apply an AED immediately. For a myocardial infarction, heart attack, administer aspirin to prevent further clotting and nitroglycerin if it is prescribed and the blood pressure is stable. If the patient is in decompensated shock, where the body can no longer maintain blood pressure, keep them warm, lay them flat, and move fast. In the neurological and environmental realm, we treat status epilepticus, seizures lasting more than 5 minutes, by protecting the patient and clearing the airway. For opioid overdose, provide BVM ventilations and naloxone. For heat stroke, perform aggressive active cooling with ice packs to the neck, groin, and armpits. Your goal is to stabilize the ABCs. If you see a hole, seal it. If the heart stops, pump it. If the blood is out, stop it. Stay calm, follow your sequence, and treat the most immediate threat.